Yeah, just my take on things. My answer to number 2. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Those cognitive distortions.
Welcome to our 4th episode of Peplau's Ghost. My name is Dan Wesemann, back again for our next episode here. I'm really excited and thankful so much for you to be listening here. Really kind of took a look and actually looked at our audience. I understand most of you guys are from the United States, but there is actually reaching out across the pond, as they say. I've got a couple of listeners over in Denmark. So I really want to give a shout out to those people and thank you so much for following along with Peplau's Ghost. Also wanted to kind of make an announcement that we are going to kind of change our format a little bit here. We're really excited to have a super interesting guest, Dr. Cynthia Handrup from the University of Illinois, Chicago. And so that's going to be kind of our moving forward. We're going to have different people from all across the United States who are experts and really kind of thought leaders on using psychotherapy within nursing and the nurse practitioner role and such. So I'm really excited to kind of get into her and kind of talk about it a little bit and kind of really find out some more information. So I'm really excited about these questions. So let me do a quick introduction. I already mentioned this to Cynthia that she can correct me if she wants, but again, Cynthia Handrup is a well-accomplished leader within psych mental health nursing. She received the fellow, the American Academy of Nursing, back in 2021, which I'm surprised. I thought that was like last year. When I saw that, I'm like, but that's great. I think, isn't that like the top 10% of nurses get that? So, I mean, it's a very prestigious thing. So congratulations.
Yeah. Thank you.
Yeah. And so that's well-deserved. She's received her DMP from the University of Colorado, MSN from St. Xavier, and actually her BSN from Rhode Island. So that's kind of interesting. Been around. So that's cool. East Coast, Midwest, and things like that. And Mountain Time, I guess, too. She's also somewhat recently the past president for the Global Alliance for Behavioral Health and Social Justice. And that was just last year, right, Cynthia? You just got off that as past president, or are you still past?
I finished being past president, yes. But I have been on that board for a long time and in presidency. But I am no longer past president. So I'm totally done.
And I get always mixed up. What was that organization called before the Global Alliance?
So we just celebrated our 100th anniversary, and it used to be called the American Ortho Psychiatric Association. And it is one of the very first interdisciplinary associations back in 1924. Carl Menninger was one of the founders, and the seal includes professions that are included in the organization, and nursing is actually in the seal. And the other thing is that I was only the second nurse to be president. Claire Fagan was president in the 1980s, I believe. So, anyway.
That's very cool. Yeah, I will apologize. I don't know much about that organization, but from your involvement, I've gotten to know more a little bit and hopefully get more involved with that later too. So she's also currently, mentioned already, she's faculty as well as I believe the program director for the Psych Mental Health Nurse Practitioner Program, University of Illinois in Chicago. She's also in private practice, again, kind of doing a little snooping. I think your practice name is Handrup and Associates, and got some cool people there in Chicago that you see as well. So this, again, as you know, Peplau's Ghosts here, our podcast is very focused on psychotherapy. Saw that flashed all over your website. So you still practice that and practice what you teach, as they say. So really happy about that too. And so another thing I saw, you've received the President's Award from the International Society of Psych Nurses in 2013, and a lot of other things, a lot of HRSA grants and other things. When you start looking through a bio and you see these $1 million grants and things like that, you kind of know you made it. So again, very pleased that you're here with us, Cynthia. And one of the things, I know we've got a list of questions, and I'm going to kind of take us off on a sidetrack. This is something I've been thinking about a lot, and I want to kind of do this and maybe make this kind of part of what the podcasts are, kind of our signature thing maybe. But Cynthia, you and I have known each other for a while. Do you remember the first time we seen each other, or first time we met? Do you remember that?
Was it through ISPN?
I don't know if, so I was thinking it was either through ISPN at the conference. We met at a conference. I was presenting on pediatric bipolar, and you attended so graciously and sat through because I was probably not very good, but a nice long pre-conference. And I know you attended that. That was one of my first ones. And then I think either that or there was an advisory board that you invited me to as well.
Yes, but I knew you before I invited you to the advisory board. Yeah, so I think it's through ISPN. I know you were here in Chicago doing some of your studies, but I don't think we ever crossed paths when you were here, even though we are literally like blocks from where you were.
Right. Yeah. Yeah. I got my DMP at Rush. So yeah, it is literally, it's like a couple blocks from each other, and that's just how big cities are. So, but yeah, I'm always kind of interested in, kind of thinking back. I thought back too with, first time that Kate and I met each other. I think that was through NOMF, and as we were both, the chair and co-chair of that group. And I still remember we had that big meeting coming up, and we had that breakfast where we're kind of planning what are we gonna talk about for 4 hours, because that was kind of intimidating for me as well. Do you remember anything else about that, Kate? Or is that the first meeting? That's the first thing you remember, or first time we met each other?
Yeah, I remember that breakfast well, Dan. Yeah, and I remember actually the first time I met you was the very first NOMF Psych Special Interest Group meeting that I had attended. And I remember that you were the chair and you were looking for a co-chair. And I was sitting next to my colleague, Beth Phoenix, who's very well known in the psych mental health world. And when you said, does anyone want to be my co-chair? Beth took my hand and raised it for me. And she said, you can do this. And I was like, okay, if Beth has faith in me, I'll do it.
And the rest is history. Right, that's great. I know, it's so cool. And Melissa, I don't, I've not officially met you. I mean, this has all been kind of a virtual world. I hope our paths do meet one time, but that'll be our first meeting too. So, or is there anything that you remember from my first email or first Zoom meeting or anything like that?
I just remember Linda Hand connected us because I had worked with them on another initiative.
Yeah, Linda through the college and in the research department. So yes, that's how we know each other for sure, and been very thankful to have you a part of my life too. So. Awesome. Well, that's always kind of something interesting to think about. We meet a lot of people in the world, and sometimes we just meet them and we go on with our lives. But again, thankful that all you are in my life at this time. So, all right, enough divergent. Let's get into the questions. So, Cynthia, when was the first time you got interested in psychotherapy? Can you kind of share what drew you and what kind of, your first thinking about that?
Yeah, that's a great question. So I am probably a bit older than most of you here. And so when I became an advanced practice nurse, went to my master's program, it was a program it was a psychiatric clinical specialist program. And back then, advanced practice nurses were not prescribing medication. So my 2.5-year master's program was all psychotherapy. And my clinical placement was in a mental health clinic. I worked in 2 different clinics. And so right from the beginning, I guess, in terms of being an advanced practice nurse, I was always psychotherapy. Being a psychotherapist was my role. And prior to that, what attracted me to psychiatric nursing was the sort of old Hildegard, concept of use of self. And, I went to a very traditional, nursing school and did all these rotations, and psych was my last rotation. And, prior to psych, I was going to be a intensive care nurse. And then I got into psych, and it was like, it just spoke to me, and I felt I could do so much more. And I've never looked back, and have never really done anything but psych all of my life. And certainly from a historical point of view, have seen many, many changes. But I can tell you that there was a time when advanced practice nurses in psych, we did psychotherapy. That's what we did. So much has changed nowadays. So.
Yeah, I liked how you said that. And I talk to students about this all the time who are prospective, students for the program and such. I think either people get psych or they don't. I mean, I don't think there's much of a gray area. It just either clicks for them or it doesn't. And so, when I tell my students that are prospective, tell me about that. Tell me about what makes it click for you. And so yeah, thanks for sharing that. That's awesome. It's it's hard to believe these days. I mean, that psychotherapy was it. That was the thing that was king, that was, if you weren't doing
it's sort of amazing. Those of you, and many of you, we're all, many of us are, running these programs, and, students come in with such a conception of being a prescriber, and the preceptors are just prescribing. And so the lost art of psychotherapy is so, I think they can't even put their heads around the fact that we actually had a 2.5-year program that was just therapy.
Right. Awesome.
Yeah.
Thanks.
Cynthia, that's so interesting. I actually was teaching one of my classes last week, and in this class, students bring cases to discuss. And inevitably, the questions they have about the case are always about medication. And so, I always say, let's hold on a second. Let's dial this back. We need to look at the much broader picture. And in our checkout last week, one of my students said, Kate, you help us see that this work is so much more robust than just the meds. And I was really grateful for that comment. And it just goes back to what you're saying, is that I think so many of our students do have a very narrow view sometimes of what is possible for them in their practice.
Mm-hmm. Mm-hmm. Definitely. Yeah.
So, Cynthia, my question for you is, do you remember, if we can say, your first quote unquote success story with using psychotherapy?
Oh, that's a really interesting question. Yeah, and when I think back to my early sort of experiences in psychotherapy, I think back to my clinical experience as a student, and I was in a community mental health clinic. Obviously, the only nurse. The other two students, I think, were social work students. I was supervised by a psychiatrist and by a clinical psychologist, but I do remember those patients well. I remember working with a woman, a young mother who was single. We were kind of in a fairly affluent area of Chicago, this clinic was, and her child was attending a very sort of exclusive private school on a scholarship. And I remember working with her a lot about how she felt so inadequate among all these other parents. And, of course, she presented with depression and, anxiety and all kinds of questions about, am I not a good mother and that? But really what it came down to was this, and of course, from her childhood, this sense of not fitting in. And this experience just exemplified that. I mean, if any of you have sent your kids to a private school or know sort of what that very exclusive kind of environment could be like. And what's kind of telling about that, I worked with her for I think I was at this site for 9 months. We also did very long clinical placements then. And I remember, and so that was like, it was probably somewhere in the, 80s. And then I went on and did many things. And then I've been in a private practice for a long time. And about 20 years after, I get an email from this patient, and she looked me up. She was now much older and had been married and had some other issues going on, but had remembered our relationship. And actually, back then, the clinic I was in was an Adlerian clinic, and we did, if any of you are familiar with Adlerian lifestyles, and I did a lifestyle on her because we had to do it on every new patient. And back then, it was paper and pencil. And this woman had kept the lifestyle assessment and interpretation, and she did come in and see me, and she brought this relic to me, and I sort of kept it in my drawer. But that was really a pretty, significant and kind of impactful experience. That it clearly meant so much. And here I was a, first-time student, but I really connected with this patient and obviously helped her a lot. And she remembered it 20 years later. And
that's awesome. That's awesome. Yeah, that reminds me of, it's like, it seems like a folklore now, but that old story where the teacher makes them write down all these things and the whole class keeps the form and things like that too. And so then they come to their 20-year class reunion, they still got all this, what makes them a good person or something like that. So yeah, if it's okay to share, I had a patient like that once where really struggling with just some self-doubt. He had a chronic pain issue and unfortunately was on long-term opioid use, but, kept feeling like the pharmacist, whenever he went to get his meds refilled, was looking at him like he was an addict. So we wrote in a little Post-it note that said, I am not an addict, which he wasn't. But yeah, he put it in his wallet, and yeah, like 10 years later, pulled out his wallet. He had another interaction with him and still had that Post-it. And it's like, oh my gosh, it's sometimes you don't know the words you use and the impact you have. You just don't know sometimes. Yeah. That's great. Thank you, Cynthia, for sharing that story. That's awesome.
It's making me smile as a patient of psychotherapy. I keep every assessment that I've ever had. I'm also like a kind of a paper hoarder a little bit.
Yeah.
It's meaningful.
I think I remember being in analysis once and doing a lot of dream work. And I used to keep, I used to write dreams down on a piece of paper, and I remember keeping those pieces. So I would always remember those dreams and then what the analyst and I talked about afterwards. But yeah, I think, we miss a lot of that with our phones. So
definitely.
Very true. Very true.
Curious, you have such a wealth of experience and many years, if there are forms or types of psychotherapy that you're more drawn to. Yeah. And if that's evolved over time or changed in any way.
Yeah. Sure. So, as I always tell my students, and I think just, given sort of the time that I came up in. I'm pretty psychodynamic. I did, when I first finished that master's program and was an advanced practice nurse and was doing therapy. I live in Chicago, and in Chicago we have one of the 14 training analytic institutes. So I went to a year-long program at that time, which was for psychotherapists in psychodynamic psychotherapy. And it met every Friday afternoon from 1 to 4. And again, I was the only nurse. There were social workers and, other master's level psychologists in that. But that was probably really extremely a big part of my foundation. And, back then when I was in school too, psychodynamic or psychoanalytic theory was really kind of the basis for the other theories. The other thing I did as a new therapist, a new practitioner, is I sought out individual supervision for myself. That was after that program at the Analytic Institute. And I don't know, you probably have heard of Heinz Kohut. His wife, who was a social worker, also a therapist, lived, and she's now dead, in Hyde Park, part of Chicago, near University of Chicago. And so I went to see her for about a year for individual case, just for, supervision. And I remember that what she did, which is kind of a part of psychotherapy, I think, is, and which I've done with students, is that she said to me when we started out, I don't want you to come in every week and just report to me what's going on with your patients. I want you to pick 2 or 3 patients and let's follow them. So every week when I came in, she wanted to know what was going on with Susie and with, Bill. It was like, I didn't just spew out I think I started bi-weekly or something, but it was an interesting way of doing supervision, I thought, and it helped me when I became a supervisor of psychotherapist, was this idea of a sort of evolving case. Like, let's every week or every, 2 weeks, see what's going on with this person, and kind of, rather than, like telling you all the horrible things that I dealt with this week, that kind of thing.
Yeah. I
other
can get lost with that.
Yeah, I think, the psychodynamic stuff is certainly foundation. It's the way I think when I, conceptualize patients' problems. I certainly do some CBT. I do see some families. I see couples probably more than families. But in general, sort of what governs how I theoretically conceptualize a patient's problem is psychodynamic stuff.
That's great. Thank you. Something you've said a couple times now, just to kind of pick up, you mentioned that you've been the only nurse in the room in a lot of these situations. So
yeah.
Did it, and this isn't one of our questions, but I'll kind of go off on track a little bit. Did you ever consider getting out of nursing? I mean, do you like becoming a psychologist or a social worker? I mean, that was the path of least resistance at that time, right?
No, that's an interesting point, because I didn't ever think that I should go to medical school or become a clinical psychologist. I think those would be the two things I would have thought about. But I've always felt that nursing was this special, unique profession that wasn't the same. My husband is a psychiatrist. We think differently about patient problems. He has a different approach than I do. I mean, I think it can complement each other. I've known many, many clinical psychologists. And again, I think, what they do is somewhat different. I think, we're all, you've probably heard the concept of the fifth profession. It was a concept by Lee Sprague, that there were 5 professions that do psychotherapy: medicine, physicians, psychologists, social workers, and psychiatric nurses. But he called it sort of like it was its own little profession, because we are sort of a unique splinter group, if you want to say, from some of when we go to like big psychiatric nursing conferences or conventions, or we just get together. The people who do psychotherapy are sometimes a little, special interest group or something. But that kind of thing. But no, I never have thought that, Dan, and I have, because I've been around. Certainly it's different now. There's lots of nurses, attending things. But, I've been in rooms where people have said to me, well, why, I had no idea that psychiatric nurses did that, that kind of thing. Or, you should have gone to medical school. You should have been a psychiatrist. You should have gone to, and it's like, well, no, but I didn't want to. And, it was that sort of thing. So I don't think I've ever had that feeling that I was in the wrong profession.
Cool. Thank you. It leads to my next question, actually, as I'm looking at the question list here. So how do you see nursing being a leader in performing psychotherapy?
Well, that's I think, kind of the crux of what we're all here about. And, what was so exciting about the podcast when you told me about it, that it was really focusing on psychotherapy. If you sort of go through my list of, on my CV, back, I think it was maybe in the late 80s, early 90s, I once did a presentation at ISPN with Kathy Delaney, who I think is going to be one of your future guests. And we titled our presentation, "What Would Peplau Think?" And it was about what was happening in psych NP programs, about the loss of psychotherapy, the loss of that role. And it was a while ago. I'd have to check my CV. We also wrote a paper on it too, I believe. But it was, we were concerned. And I mean, at that time, I wasn't even I was still just I was a clinician. I wasn't doing psychotherapy. I mean, I wasn't teaching in a program. I was precepting, that sort of thing. But she was director then, I think, of the Rush program. But it's a big concern. And, at our program, we still have a psychotherapy course. We still have one of our clinical rotations focusing on psychotherapy. I try to, use social workers as preceptors for students at least like one day a week when they're in the psychotherapy clinical practicum, because it's so hard, as you all know, to find them. But every once in a while, I mean, in every class, we have a pretty big class. I would say there's about each of our incoming classes is about 20 students. There's always a handful that want to do psychotherapy. That is what they want. They want to learn that. They want that to be part of their skills. So I don't know, Dan, if it's a PR job, if we have to sort of do more of it that way, but it concerns me because I know there's programs where very little is mentioned even about psychotherapy.
Yeah. That's why we're getting together, right? I mean, I think it is a PR thing. It's getting more visibility. And I look at it as a pendulum swinging, right? It's, the pendulum started with psychotherapy. Now it's swinging huge to, 80s and 90s for sure. Started with Prozac and all the other medications, which again, saves lives, nothing against medications, but now, this swinging back to more of kind of a center lane where we can actually do these sort of things. Cause we know meds don't fix everything, and they have side effects that we just don't intend to have. So it's, well,
and Kate, I like what you said about with your students, telling them, that they learned from you that there's more to the patient. I mean, I often tell students, you don't have to prescribe medication the very first time you see this patient. You might have to see them again because you don't have the full story. You don't know I mean, obviously, unless someone is, not safe and, really psychotic or suicidal, but, they're throwing medications at patients before they even really understand. You don't always get that in 45 minutes or an hour. Sometimes you need a couple more sessions to.
Absolutely. And I think, so many of the patients we treat are really complex and we need to get to know them before we can start making, really solid treatment determinations like that. I completely agree.
Yeah. But somehow people have gotten this notion, some providers have, and I know a lot of psychiatrists have this, is that if a patient comes to see me, they want to leave with a prescription. And I just, I tell many patients that, I need to continue the assessment before we make any decision about medication.
Absolutely. And I think so much of that is workplace culture and, pressures as well. I'm reflecting on right now, I recently joined a interprofessional team that does house calls for patients who are homebound, bedbound for whatever reason. And I'm the psychiatric nurse practitioner on that team. And I feel very confident that I have the leeway on that team to say, I'm just getting to know you for the first 2 visits, barring anything very acute or, so on. We need to get to know each other before we can, really start to talk about some of these things. And also because you have to actually trust me. And I think that almost seems like a luxury these days to feel supported in that.
Yeah.
And so Cynthia, on that note, I'm curious, what do you think are the barriers for more psychiatric nurse practitioners using psychotherapy in practice?
Well, maybe, I think you touched on a little bit by saying about where people work or, the agencies or something. I think a little bit it is of the marketplace, if you will, wanting, if you're a prescriber, that's what they want you to do is prescribe. When I say they, meaning like the administrative people of a clinic or, It's very interesting. I also, we have kind of a mental health family. I have a son who is a social worker, and there's never any question that he does therapy. I mean, it's never, that's all he does. And, but I think because we have that role, and we also have that ability to prescribe, that we sometimes, and this is what I think happens to the new grads, is they get sort of like told, this is what you need to do. And they don't really advocate for themselves to say, well, I want to also do psychotherapy, or I want to also have so many cases, that kind of thing. So yeah, I think it's maybe, market driven. That's just a thought of mine, but there is but psychotherapy is alive and well with these other professions. I mean, it's, that's so, how do we keep that in our sort of tool chest or rubric, or, as a major part of, it's a major part of my identity, is being a psychotherapist. And certainly before I was an academician and was just a clinician, I described myself as a psychotherapist. And when people said, what do you do as a psychiatric, advanced practitioner, I said I was a psychotherapist, and then we added on this evaluation and medication piece. But
awesome. I think Melissa's got the last question.
I think that ties really nicely into our last question of what is the future in your view of psychotherapy for PMHNP? Yeah.
I think we have to just sort of keep doing things like this podcast. And I think we have to keep on, Dan, somebody once, in fact, I'm not doing one this year at ISPN, but I think someone, maybe it was Beth Bonham, said that for the last 15 years, she said, Cynthia Handrup's always there presenting something on psychotherapy. And I just think we have to sort of keep it alive, I guess, and that we have to do stuff like that. We have to sort of keep talking about it. And, and I think that's one of the things I really like about being the program director of a Psych NP program, is I get to sort of help mold some of those young people. And there, like I said, there are a handful that's really what they want to do. And then just, or even I had a student last year who didn't think she wanted to do psychotherapy, but I did have her spend one day a week in a social work practice. It was all psychotherapy. She ended up loving it. She did an extra over the summer. She did an extra clinical with them. And and it's interesting now, when she went back and did her last clinical with a Psych NP who was mainly a prescriber, commented on how much better her skills were therapeutically with patients now. And and she definitely was somebody who got sort of sold on how important this was. But so yeah, I think in our role with directing these programs, to make sure that we provide those kind of experiences and talk about it. I have a panel of who I call nurse entrepreneurs or nurse leaders come and talk to the graduating class and there are people who have gone out on their own after they get full practice authority and opened their own practices or their own clinics. And they all say, when the students ask them why they did it, they all say they did it so that they could practice psychiatric nursing the way that they thought it should be practiced, and didn't want to, follow the sort of, mandates of some clinics and that kind of thing. So, yeah, I think it's just exposing the new generation and keeping it alive. That would be
Yeah, that's awesome. I know. I think, and again, I think that's what we're all doing here too, is really trying to promote that and highlight it. Unfortunately, my brain kind of keeps going to things that just seem really unchangeable, but I'm hoping they are. But it has to do with reimbursement rate too. I mean, I think if there was just more availability of funds, it highlights the value of it in practice, in society, and things like that too. So, but maybe, like I say, you get more people, you get more momentum behind it. That's going to be the way to do it too. So obviously it's still here, we haven't gone away completely, which is great. And, so thank you so much, Dr. Cynthia Handrup from the University of Illinois, our first guest. Round of applause for on Peplau's Ghost. So thank you so much for sharing your time and your expertise. And thank you so much for listening as well. Please like, subscribe, and comment to the podcast. And we'll look forward to us having our next guest soon. Take care. Bye.
Okay.
Global labeling, emotional reasoning. Too much salt like this, too much seasoning. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.